Okay, let's go.
All right, I want to start us off with a quick word association game. I'm going to say a phrase, and I just want the first image that, pops into your head. Ready?
Yep, I'm ready. Go for it.
Shock therapy.
Oh, that's easy. Jack Nicholson. It's One Flew Over the Cuckoo's Nest.
It is always Jack Nicholson.
Every single time. You see that scene, right? He's being held down. It's chaotic. It looks like a punishment. It's terrifying.
Exactly. And that film came out in 1975. But here we are almost 50 years later, and that one scene is basically the cultural software for how we think about this. It just cemented this idea that it's barbaric, a form of torture.
It did. It completely froze public perception. And here's the pivot, and it's a big one. That cinematic image has almost zero relationship to what actually happens in a hospital today. In fact, if you look at the science we're diving into, electroconvulsive therapy, ECT, is, well, it's arguably the single most effective, fastest acting treatment we have for severe depression.
See, that's a huge claim. The most effective.
It is. I know. It sounds like an exaggeration, but the data is pretty clear. We're not talking about a small improvement. We're talking about remission rates that just blow standard antidepressants out of the water.
So that's our mission for this deep dive. We're going to try to strip away the Hollywood horror and look at the actual science. We'll get into how it evolved from the 1930s, what the procedure really looks like, and the big question: how does a seizure reboot a brain?
It's a fascinating story, a mix of accidental observation and decades of refinement.
Okay, so let's start with the basics. When we say ECT today, what are we actually talking about?
So, in simple terms, ECT is a medical procedure. It's done under general anesthesia, and a doctor passes a very small, controlled electrical current through the brain. The goal isn't the electricity, that's just the trigger. The goal is to induce a brief, generalized seizure.
And I think that's the part that gets everyone. You're intentionally causing a seizure. In any other context, a seizure is a medical emergency.
Yeah.
So why would doctors decide to cause one?
Right. To get that, you have to go back to the 1930s. Doctors started noticing this really strange pattern in patients who had both epilepsy and schizophrenia.
Okay, what were they seeing?
Well, they saw that right after one of these patients had a natural spontaneous seizure, their psychotic symptoms would just vanish. The delusions, the hallucinations, they'd clear up for days, sometimes even weeks.
Huh. So nature was kind of giving them a hint. The seizure was like a reset button.
Exactly. There was this idea called biological antagonism.
Yeah.
That you couldn't be both seizing and psychotic at the same time.
Yeah.
So the thinking was, well, if a natural seizure works, can we induce one on purpose?
And before electricity, how did they try that?
Oh, it was a mess. They tried chemicals like camphor, which was really unreliable. Then insulin shock therapy, which was super dangerous. Electricity just turned out to be the quickest, most controllable way to get it done.
Well, we have to touch on the dark era because that stigma, it came from somewhere. The early days were pretty rough.
They were, yeah. We're talking the 40s and 50s. You have to remember, we didn't have antidepressants or antipsychotics. So ECT was the only tool they had for really severe mental illness, and it was used for everything. But the real problem, the source of all the horror stories, was the lack of safety protocols.
This was the unmodified ECT, right? No anesthesia.
Exactly. No anesthesia, and the big one, no muscle relaxants. So the patient was awake, and when the seizure hit, the physical convulsions were just incredibly violent. People would fracture their own bones.
That's horrifying.
It is. It's brutal to even think about. And that is what One Flew Over the Cuckoo's Nest showed. That was the reality then. But, and I really have to stress this, the practice has been gone for decades.
So paint the picture of the modern version. What does it look like now?
Honestly, it's boring. It looks like any minor outpatient procedure. The patient is completely asleep under general anesthesia.
Yeah.
And they're given a paralytic, a muscle relaxant.
So they don't move at all?
Barely. You might see a tiny twitch in their toe. That's it. In fact, the muscle relaxant works so well that doctors have to use this little trick just to visually confirm the seizure is happening.
A trick? What kind of trick?
It's called the cuff method. So before they push the drug that paralyzes the whole body, they put a blood pressure cuff on one ankle and pump it up really tight.
Oh, like a tourniquet.
Exactly.
Yeah.
So the drug goes everywhere else, but it can't get to that one foot. The rest of the body is still, but that one foot will start to twitch, and that's how they see it, along with the EEG on the monitor, of course.
That is a detail I have never heard. It's so controlled they have to leave one foot awake just to watch it work.
It's calm, it's controlled, it is completely undramatic.
Okay, so if it's so much safer, why is it still seen as a last resort?
A lot of it is just the stigma we've been talking about. And it is logistically complicated. You need an OR, an anesthesiologist. But from a clinical standpoint, for some conditions, it really shouldn't be the last resort. It should be the first-line treatment.
Yeah, I was looking at the list of indications. The key word seems to be urgency.
Speed, that's the key. Your standard antidepressants can take, 4 to 6 weeks to even start working? And that's if they work at all. If you have a patient who is actively suicidal or so depressed they've stopped eating and drinking, you don't have 6 weeks.
You need something that works now.
Right now. ECT works fast. You can see improvements within a few treatments. In a life or death scenario, that speed is everything.
The other one that really surprised me was pregnancy. I would have just assumed electricity and pregnancy do not mix.
It sounds totally counterintuitive, doesn't it?
Yeah.
But you have to think about the alternative. Severe psychiatric distress in the mother is also incredibly dangerous for the fetus. And a lot of psychiatric drugs can cross the placenta and pose their own risks.
So the meds are actually the bigger danger there.
They can be.
Yeah.
With ECT, the electrical current is just in the mother's brain. It's localized. As long as you monitor everything carefully, it's often considered the safest and most effective option in those high-risk cases.
That completely flips the script on what safe means. And it's not just for depression, is it? The sources mentioned Parkinson's.
Yes, Parkinson's, and even something called refractory status epilepticus.
Which is a seizure that won't stop.
Exactly. A non-stop seizure that isn't responding to medication. It sounds like a paradox, using a seizure to stop a seizure. But by inducing this controlled seizure, you can sometimes break the cycle.
Is there anyone who absolutely cannot get ECT?
You know, it's surprising, but there are no absolute contraindications.
None.
Not a single one. There are only relative ones. Things like a very recent heart attack or stroke or maybe a brain tumor that's increasing pressure in the skull. The risk is higher, sure. But if the person is going to die from their psychiatric condition, you might still do it.
Okay, let's get into the how. How does it work? You said the electricity is just the trigger.
Correct. The medicine, the therapeutic agent, is the seizure itself.
So what is the seizure doing? Because our default is that seizures are damaging.
This is where the neuroscience gets really cool. We don't know the exact mechanism for sure, but we have some really strong theories. The first one is the neurotrophic hypothesis.
That's the one with BDNF.
Yep. Brain-derived neurotrophic factor. I always call it miracle grow for your brain cells.
Fertilizer for the brain.
Exactly. We know that severe depression literally causes parts of your brain, like the hippocampus, to shrink. The neurons wither. It's physical.
So it's not just a mood, it's actual structural damage.
It is. And ECT causes this huge release of BDNF. It jumpstarts the brain's ability to repair itself, to grow new connections. It's called neuroplasticity.
So you aren't frying the brain, you're fertilizing it.
In fact, we see brain volume increase after a course of ECT. It's restorative.
That's the complete opposite of the brain damage myth.
Completely. And there's another theory I find even more fascinating. It has to do with a neurotransmitter called GABA.
Okay, what does GABA do?
GABA is your brain's main braking system. It's inhibitory, calms things down. When you induce a seizure, the brain's immediate reaction is, whoa, way too much activity. And it dumps a massive amount of GABA into the system to shut the seizure down.
Like an emergency fire suppression system.
A perfect analogy.
Yeah.
And for someone with depression or mania, their braking system might be faulty. This massive flood of GABA seems to reset that whole system. The calming effect just lingers.
So you push the system to the very edge just to force it to build its own safety net.
Precisely.
Okay, let's walk through the actual procedure. I'm the patient, I've fasted. What happens when I get into the room?
Safety's everything. Yeah. And there is one golden rule for the medication order. Anesthetic first, then the muscle relaxant.
Why is that order so important?
Because the muscle relaxant, succinylcholine, it paralyzes everything, including the muscles you use to breathe. If you gave that to someone who was awake, they'd be fully conscious, unable to move, unable to breathe, just terrified.
A total nightmare. So you put them to sleep first.
Always. You're asleep, then the paralysis happens. Then they put in a bite block to protect your teeth and tongue because the jaw muscles can still clench a bit.
And then the electrodes. I noticed in the notes that where you place them really matters.
Oh yeah, it's a huge trade-off between how well it works and the side effects. The standard place to start is called right unilateral, or RUL. One electrode on the top of the head, one on the right temple.
And why the right side specifically?
For most people, our left brain hemisphere is dominant for language and verbal memory. So by keeping the electricity on the right side, you can spare those centers and reduce the cognitive side effects.
But there's also bilateral on both sides.
That's the heavy hitter. Yeah. If someone is acutely suicidal, catatonic, or RUL just isn't working, you go bilateral. It works faster and more powerfully, but it comes with a higher risk of memory problems.
And after the stimulus, how long does the seizure need to be?
The therapeutic sweet spot is about 30 seconds or more. If it's too short, it doesn't really work.
And I saw this wild detail. If it's too short, they might actually give the patient caffeine intravenously.
They do. Caffeine lowers your seizure threshold, makes the brain a bit more excitable. So sometimes, they give a little caffeine to make sure they get a good, robust therapeutic seizure.
That is just wild. Okay, memory. Let's go there. This is the big one for people. Will I forget my own name? What's the reality of the memory loss?
We have to be direct about this. Memory loss is a real side effect. It's the main drawback, but it's usually very specific. It's some retrograde amnesia, so forgetting things from the weeks right before treatment, and anterograde amnesia, so trouble forming new memories during the weeks of treatment.
So the whole hospital stay might just be a blur.
Exactly. People call it a Swiss cheese memory for that specific block of time. But the fear of, a total identity wipe, forgetting your family, your life, that is extremely, extremely rare.
It's more about impersonal facts than personal identity.
Yes. You might have trouble remembering the capital of a state for a while, but you won't forget who your kids are.
And does it come back long term?
This is the surprising part. For most people, a few months after the treatment course is done, their cognition actually improves beyond their baseline.
Improves? How is that possible?
Because severe depression itself is a cognitive nightmare. It kills your concentration, your memory, your processing speed. When you finally lift that heavy blanket of depression, your brain can just work again. So the net effect is a gain.
What about physical side effects? Pain.
Headaches are common, jaw pain too, and general muscle aches. But funnily enough, those aches are usually a side effect of the muscle relaxant, not the seizure itself.
Let's talk about the ultimate safety stat, mortality. How dangerous is this, really?
This is the number that just stops people in their tracks. The mortality rate is about 1 in 98,000 treatments.
1 in 98,000.
To put that into perspective, it's on par with, or even safer than, getting general anesthesia for a routine colonoscopy. It is safer than childbirth.
And I think I read that the all-cause mortality actually goes down for these patients.
It does. It's a paradox. People who get ECT live longer than similar patients who don't. And the reason is simple. You are treating a fatal illness. You are preventing suicide. The risk of the treatment is tiny compared to the risk of the untreated disease.
So if it works so incredibly well, like up to 90% response rates, why isn't it a permanent cure?
And that's the tough part. It's an incredibly effective treatment, but it is not a cure. It gets you out of the crisis, but it doesn't necessarily prevent you from falling back in. Relapse rates are pretty high. If you just do a course of ECT and nothing else, about half of people will relapse within a year.
So what's the plan then? You can't just keep getting it forever.
Well, you transition to what's called maintenance ECT. You taper the treatments down maybe once a week, then once a month. And critically, you combine it with medication like lithium or nortriptyline to help lock in the benefits.
So it becomes part of a long-term management strategy.
It does. But for someone who's lost years of their life to crippling depression, having a life that requires maintenance is, pretty good trade.
It really makes you question our definitions of humane, doesn't it? We see ECT as this radical, extreme choice, but maybe leaving someone to suffer for years with treatments that aren't working. Maybe that's the more extreme option.
That's the conversation. That's exactly it. We have this life-saving tool that sits on the shelf because of a movie that's almost half a century old. We're letting stigma get in the way of care.
So before we wrap up, what's the one last idea you want to leave people with?
I think it comes back to that idea of the seizure threshold.
Go on.
In almost every other part of medicine, we see a seizure as a failure of the system. It's a bug. It's something to be stopped at all costs. But ECT forces us to see it differently.
How so?
It suggests that the brain's own powerful defense mechanisms, that huge flood of GABA, that desperate attempt to restore order after the chaos, that's the medicine. We aren't really fixing the brain from the outside. We're just creating a controlled crisis that forces the brain to heal itself.
Pushing the system to its limit, to find its own calm. That's a powerful place to end. Thank you for this, for really clearing up so many myths.
My pleasure. It was great to talk through it.
And to our listener, thanks for joining us on this deep dive. We'll see you next time.